was to take you on a journey of what interventional radiology has opened up in ensuring that patient gets better care. Now, in my talk today, I'll take you through the long journey over the last century or so that interventional radiology has seen. I'll also touch upon the basic requirements for starting an interventional radiology unit and actually why interventional radiology is trending per se, whether it is actually needed or not. And I'll take you briefly also across the various IR procedures, especially for the benefit of youngsters who are joining today. I'll also share with you certain concerns that the specialty at large faces as well. Now, the journey of interventional radiology actually started more than a century back when Hashek and Lindenthal tried to cannulate a radial artery of a cadaver and tried injecting contrast and took an X-ray angiography to visualize the vascular tree of the upper limb hands. Now, this was basically on a dead body, but further on, there were attempts to directly cannulate arteries in animals and further in humans as well in order to take angiographic pictures. However, always this vascular access was an issue, which until 1953 was always unsolved. In 1953, Seldinger found out a technique of inserting a cannula into an artery or a vein and then inserting a wire and over the wire inserting a sheath into an artery or a vein so that this sheath can be used and kept in situ so that multiple hardwares can be serially or subsequently be inserted without puncturing the artery multiple times. Now, with this technique being identified, it was actually a decade later in 1963 that Charles Dotter, who is now presumed to be the father of interventional radiology, went on to do the intentional subintimal angioplasty of the SFA, this being the first beneficiary, one 80-year-old Laura, who post the angioplasty actually benefited by saving her limb from amputation. From then on, interventional radiology has grown a lot. Now, what you need to actually start an IR unit, basically, the main workhorse of your interventional radiology unit is always the DSA system or the digital subtraction angiography system. You have a lot of interventional hardware, the basic ones being the access sheath. This is the access sheath that you insert more commonly into your femoral artery or into your radial artery. And nowadays, it can be inserted at multiple other sites as well. So this is basically the access to the human vasculature. Now you have differently shaped catheters which are used depending upon particular or specific arteries which you need to cannulate. You have wires which will help these catheters to reach their destination. You have various balloons that will help in opening up narrowed segments of vessels. And you have stents that will help in keeping that narrowed vessel after opening to be patent for longer duration. You have embolic agents like liquid embolic agents, particulate embolic agents, as well as coils as well for various indications, as we'll see along the talk. Now, more important part of your interventional setup is your support system. That includes all of you, your radiographer technologists, in addition to the nursing staff, and more importantly, also the other departments, because a larger majority of your patients will actually come by referrals from other departments in the hospital. Now, why interventional radiology and why is it actually superior to surgery in general is always a question that we may have in our mind. Now, interventional radiology always has the advantage that it will reduce the number of days the patient stays in the hospital. And the patient will be able to return to his routine activity as early as possible. Sometimes even more, many of our procedures can be done on an OPD basis as well. Relatively, when compared to your surgical procedures, the procedure time is relatively less. And naturally, when you are having only a small needle prick on your body, patient is also relatively more comfortable when compared to your surgical procedures. Now, when we started IR unit in our institute, where interventional radiology was unseen to a larger extent for a long duration, we were also skeptical whether we'll get the number of patients to keep this running. And surprisingly, actually, we in 1 year down the line that we have started our services, we've been able to cater to more than 500 patients. The only plateau during our periods being only due to the first as well as the second waves of COVID that we saw. The total number of OPD referrals per day has also increased hugely over the past 1 year. In the next few minutes of my talk, I'll take you through the various interventional procedures that can be done. And thanks to interventional hardwares that have been developed recently, we are now able to reach actually anywhere from the head till the toe. The only area that we interventional radiologists have left from our side is basically the heart and probably the coronary artery. So in general, anything above the coronary artery origin is probably what we refer to as the area of the interventional radiologist. Starting from the neuro-interventions, we can actually do angiograms after getting a femoral access to delineate the vascular anatomy of the brain, as in this case being an ICA angiogram, this being a normal vertebral artery angiogram. You can detect vascular abnormalities like a carotid cavernous fistula, as in this case where there is extravasation of contrast into the cavernous sinus. You can delineate well the feeding arteries as well as the draining veins, as in this case of a right-sided cerebral AVM. Not only in diagnosing these conditions, but also you can go one step ahead and do treatment for this as well. This was a 70-year-old patient, a hypertensive, who was brought to the casualty with significant SAH and intraventricular hemorrhage as well. CT angio was negative, but angiogram showed a ACOM aneurysm, which underwent coiling, which technically means that you're placing a catheter into the aneurysmal sac and packing the aneurysmal sac with metallic or specifically platinum based coils in order to exclude the sac from the circulation. So this was the post treatment image wherein the sac is completely occluded and the patient went on to recover normally. Now you also have other devices now which are called as web or flow diverters, which are also used for the treatment of cerebral aneurysms depending upon specific locations of aneurysms. In addition, as I already told, not only in diagnosing, you can actually get anatomy of the cerebral AVM in detail so that you can actually embolize these AVMs as well with preferably liquid agents, liquid embolic agents, which are most commonly used, as in this case, with obliteration of the AVM. The advantage of these procedures being now being done endovascularly is that the patient is back to home within a week's time and he can go back to his normal routine within a month's time, unlike the extensive neurosurgical procedures that may have that used to be done. This was a 22-year-old patient post-trauma who was detected to have a carotid cavernous fistula on the left side post-trauma. This was confirmed on the initial angiogram as filling of the contrast into the superior ophthalmic vein. The same was coiled off. The rend in the ICA into the cavernous sinus was coiled off, and the patient had a normal eye back. You can also visualize and detect your dural AV fistulas, which can also be managed endovascularly as well. Now, one of the other emergency indications of actually doing intervention is in stroke, acute stroke cases, wherein this was a case of a 52-year-old dyslipidemic patient who presented with right hemiplegia with CT showing left lentiform nucleus to be obliterated. The CT angio showed cutoff of the left MCA, the same confirmed on DSA. You have devices which can actually retrieve the clot. This one we call a stent retriever, or you have suction devices which are basically catheters which will suck out the thrombus in the occluded segment of the artery. Either of these will finally result in reopening of the artery, this being the rest of the MCA that was recanalized. The patient recovers faster with no significant morbidity post the procedure. Coming down to the neck region, the larger majority of interventions are mainly for preoperative embolization of highly vascular tumors. As this being a carotid tumor, which is highly vascular in the initial angiogram, you can cannulate the feeding arteries that supply these tumors, embolize the same so that the patient can undergo surgery almost without any significant blood loss. The same also holds true for this 24-year-old case of a juvenile nasopharyngeal angiofibroma that shows intense contrast blush in the right nasal mass. This was an increased perfusion within the mass. The initial angiogram showed intense blush within the tumor via the ECA branches, which were embolized prior to the surgery. This patient went on to have surgery and is in recovery stage. Also, in patients who are having recurrent TIAs or recurrent strokes because of stenosis involving the carotid artery, you can recanalize this tract and stent the segment to have a normal lumen with a normal cerebral perfusion so that the patient does not develop recurrent episodes further. Coming down to the trunk, In patients who are having hemoptysis, especially patients who are post-tubercular, who on CT have hypertrophied bronchial arteries, may benefit with angiograms and cannulation of the bronchial artery as in this case, and embolization is the same, which was done with particulate embolic agent, with the result that you are saving the patient from life-threatening hemoptysis with just a minimal intervention. So also is the case of pulmonary AVMs. This was a case of a Osler-Weber-Rendu syndrome, wherein there was tortuous vasculature that was seen in the left lower zone. CT confirmed it to be a pulmonary AVM. Angiogram was done with cannulation of the segmental artery, with occlusion of the segmental artery using a device that is called as a vascular plug, thereby excluding the shunting of blood from the arterial to the venous side. Now, a larger majority of referrals to an interventional radiology unit anywhere will mostly be from the gastrointestinal system doctors, whether it be medical or surgical. Now, not only in treatment, one of the newer diagnostic modalities is to get a liver biopsy via the internal route, that is through the internal jugular vein or the neck vein. We can pass needles and cannulas through the IV SVC into the hepatic vein and get biopsies of the liver through the venous side. Now, why we do this is basically, especially in patients who are having coagulopathy. Many of the patients who are having liver disease will be having coagulopathy. That means they have high risk of bleeding. So if you are doing a puncture from the skin directly into the liver, there are risks that these patients will bleed from the liver surface into the peritoneum once your biopsy is over. Now, in this also there will be bleeding, but the interesting fact is that whatever bleeding is occurring will actually occur into the hepatic vein. That is, whatever bleeding is occurring back into the circulatory system, with the result that the patient will not have any HB drop or any hemodynamic compromise. One area where interventions have actually revolutionized treatment is in treatment of hepatocellular carcinomas. Now we are able to cannulate segmental hepatic arteries that supply the hepatocellular carcinoma specifically. We can embolize these tumors with chemotherapeutic agents and then occlude the vessel, with many of the patients actually having significant difference in overall survival. You can also have RF ablation, that is, you're putting an RF probe across the lesion under ultrasound guidance and ablating the tumor, as in this case. For advanced tumors, you have the option of radioembolization as well via the transarterial route. For smaller lesions, you also have options of acetic acid and ethanol injection directly into the tumor via ultrasound guidance. In large tumors where you have a risk of rupture, you can, even without a chemotherapeutic agent, you can embolize the supply to the particular tumor. Now, you also have treatment modalities in patients with pancreatitis, wherein the pancreatic and the peripancreatic region will be significantly inflamed. Now, to tackle pseudoaneurysms that develop in this bed for a surgeon is very difficult because the entire bed is inflamed. Now, for an interventional radiologist, it is relatively simple when compared to the surgeon to cannulate the vessel. This is the pseudoaneurysm. This is arising from the proximal part of the splenic artery, which was cannulated. You are coiling the segment as the splenic artery. In the final angiogram, you are seeing exclusion of the aneurysmal sac. And the patient is ready to ambulate the next day itself. In addition to aneurysms in relation to the peripancreatic bed, you can also detect bleeds that are happening into the colon or into any part of the small intestine, as in this case, from a branch of the SMA. This was also embolized with PVA particles, thereby preventing further anemia in these patients. One another area of intervention is helping gastroenterologists is in Budd-Chiari syndrome, which basically is a disease that causes a cutoff of the hepatic portion of the IVC or the hepatic vein. So basically, there is no connection into the heart as it should be there normally. Now, what we can do as interventionalists is to cannulate this hepatic vein, open up this occlusion into the right atria, as in this case, which is called as a hepatic vein venoplasty. In patients who are unable, in whom we are unable to open up the hepatic vein, what we actually do is we come up from above, we create a shunt from the portal vein into the into the IVC in the suprahepatic part. Thereby, the portal venous blood will bypass the liver parenchyma and enter into the right atria, thereby ensuring that the portal venous blood actually continues in circulation. Now, there are patients who are having mesenteric arterial occlusions who come with postprandial pain. This was a case of a 62-year-old patient who was a chronic smoker who had near complete occlusion of the celiac artery. He had complete occlusion of the SMA. Fortunately for him, he had a patent IMA that caused him to have only postprandial abdominal pain. Now, this was taken. This was the initial angiogram that showed non-filling of the with non-filling of either the celiac artery or the SMA. We tried passing a wire across the celiac artery into the gastroduodenal artery. The celiac artery was stented, and this was the final angiogram that showed opacification of the entire celiac artery branches as well as collateral supply into the SMA and its branches. We have also come to the rescue of patients who come to the casualty with trauma related injuries, especially splenic injuries, as in this case of a splenic laceration with splenic arterial pseudoaneurysm and fistula formation. The same was confirmed on angiogram, and the segmental artery that was supplying this area was embolized with no issues for the patient subsequently. One another area where treatment has actually resulted in drastic difference in patient survival outcome and quality of life is also in tumors of the biliary tract. Now, prognosis for these tumors largely was very poor, especially because their bilirubin levels never used to come down, and and because of that, they would not be able to tolerate adequate chemotherapy as well. Now, we are now able to cannulate the biliary tract and put a drain so that bile will flow outside into a bag so that the bilirubin level will come back down to normal in what is an external drainage. Or further, we can actually stent the segment of the tumor so that bile will normally flow into the alimentary canal. The result being that you can help the patient get adequate dose of chemotherapy, improving the quality of life as well as overall survival. As far as renal intervention comes, this was a 32-year-old patient who was brought to casualty post an RTA who presented with hematuria. Angiogram showed contrast extravasation from the right renal interpolar region. The segmental artery supplying that was coiled off with blush in the rest of the kidney being preserved. The patient recovered of his hematuria completely after 2 to 3 days. We have also now come to the area of treatment of benign prostatic hypertrophy by prostatic artery embolization. With thanks to the newer hardwares and microcatheters, we are now able to reach as distal into the distalmost part of the prostatic artery. This is cannulation of the right prostatic artery with the right prostatic blush, and this is of the left prostatic artery with the left prostatic artery blush. Both the prostatic artery was embolized. This was again a patient who had severe hematuria, who had a lot of cardiac comorbidities and was not a surgical candidate. He was also back to his normal routine post this procedure in a couple of days with elevation of his hemoglobin levels as well. Now, interventional radiologists have also helped in saving limbs of patients who are having peripheral vascular disease. This was a case of SFA occlusion, which was balloon angioplasty, ensuring that there is adequate flow into the distal lower limb. And now, thanks to newer hardwares, we are now also able to reach into the infrapopliteal arteries as well, with angioplasties now being able to be done for the tibials and, for that matter, also for the pedal arch as well. Also, this was a 52-year-old chronic smoker, again a dyslipidemic. He was a auto driver from Tamil Nadu who came to us with complete occlusion of the left upper limb. He had acute occlusion, and CT had showed that there was a floating thrombus in the aortic arch as well as complete occlusion of the left subclavian artery. The problem was, if there was no urgent intervention or immediate intervention at that point, it would have resulted in complete loss of this upper limb. We cannulated the radial artery on the affected side, the left side. We kept a catheter within the thrombosed portion of the artery and then injected thrombolytic agents. Now, thrombolytic agents will lyse the clots within the occluded vessels. And the result was that the patient had complete recanalization of the left. This is the arm vessels and the below forearm vessels in the final angiogram. This patient is now back to driving his auto back in Tamil Nadu. This is basically placement of an IVC filter. This is done also in patients who are having deep venous thrombosis of the lower limb. This is done in order to prevent life-threatening pulmonary embolism in patients with dislodgement of the lower limb thrombus from the in a case of DVT. Now, one another area where surgeons had difficulty because, especially because of the high chances of mortality and morbidity, was in treatment of aortic aneurysms. Now, endovascular management of these aortic aneurysms have resulted in actually reducing the hospital stay and, as told previously, helping the patient get back to his normal routine quickly. So this is repair of a thoracic aortic aneurysm by a procedure that is called as a TVAR, which basically means that you are placing a stent with a covered fabric. So this is called as an endograft across the segment of the aorta that has got the aneurysm dilation. Thereby, this aneurysmal sac will be excluded from the circulation, and in the post final angiogram, that sac will not be filling. The same treatment is also available now for abdominal aortic aneurysms as well, the term being called as an EVAR. In these, you have bilimbs. There are two limbs for the distal end in order to being placed into both the iliac vessels as well. Now, there are a lot of CKD patients who are continuously on dialysis. Now, for the purpose of dialysis, surgeons usually create what is known as a peripheral upper limb fistula. So, an artery in the upper limb will be sutured by the vascular surgeon into a superficial vein in order to create a high flow system. So, when the patient undergoes dialysis, which on a normal routine for a CKD patients will be approximately 3 times a week, each time there will be a puncture into the proximal part of the vein and the distal part of the vein. Now, because there are multiple punctures, multiple times, there are chances that these veins will undergo stenosis and occlusion. Now, we are now able to cannulate these veins, as in this case, balloon angioplasty those segments, and ensure that these veins remain patent so that the patient can go in for dialysis repeatedly. Now, not only in the peripheral part of the arm or the forearm, they can also have occlusion in the central vein, that is in the brachiocephalic or SVC. This was a left brachiocephalic occlusion that was also angioplastied and stented, with ensuring a flow from the left upper limb across the stent and back into the SVC. Now, we have also come to the rescue of gynecologists by doing uterine artery embolization, especially in postpartum hemorrhage, post an LSCS, or post even normal delivery, and also in cases of adherent placenta, wherein you are embolizing both the uterine artery. This is a fetus that is noted within, with saving the patient because of post delivery or post surgical blood loss. You can also do uterine artery embolization for fibroids, AVMs, and uterine pseudoaneurysms as well. And if you give me a chance, the list will actually keep going on and on. And I can keep on talking till the Radiology Day celebrations probably next year as well. Just to run down few of the other interventions, now we have options of varicocele embolization in gonadal vein embolization. We have options of treating varicose veins by laser therapy or sclerotherapy. We have options of recanalizing thrombosed veins of the lower limb, as in this case of DVT. We are now also able to help the transplant in surgeons as well, as in this case, whether it be for renal or for liver, wherein they have arterial or venous stenosis by balloon angioplasty in that segment. We also have treatment now for patients who are having cirrhosis and who are bleeding because of gastric varices. The treatment being called as Barto, Parto, or Carto, depending upon the embolic agent that you are using. We also have, earlier in my talk, I told that we have been able to keep fistulas that are created by vascular surgeons patent. Now, newer devices have actually come up wherein we are now able to create fistulas on the initially bypassing the role of vascular surgeons as well. We also have now options of left gastric artery embolization in order for weight reduction as part of bariatric embolization as well. Now, some of the concerns that we have in interventional radiology is always one being cost and availability of hardwares. Every now and then, newer hardwares are coming, and the cost of these are slightly on the expensive side. And many of those recent hardwares are also limited in availability in our setup. The other being the number of trained human manpower, that whether it be for interventional radiologists as well as technologists who are trained in running DSA units. But I think with the number of people who are actually being exposed to DSA in the present stage, this will be an issue of the past. And because there is always a dearth in this human resources, why there is turf erosion with other specialists, actually encroaching on what we are doing. I think as our human resource actually increases, this will also not be an issue as well. Now, if you ask me, and many people I've heard telling that radiation exposure is not a concern. Actually, I would say that radiation exposure is a reality that we have to face with. The issue is actually of respecting radiation. And I think a couple of weeks back, you have discussed in detail on what are the protection measures and the cares that you need to do when running an interventional radiology. And that adequate care and protection is something that we all need to care. And if that is done, then it is not a concern. Also, working hours are always told to be another issue, but I don't know why. But if anesthetists and gynecologists can work around their busy schedule, I think there is no problem for an interventional radiologist or a DSA technologist to actually work around the schedule as well. Before I'll end today's session with this picture of Charles' daughter. And this image was actually drawn by Charles' daughter and kept in his clinic. This was actually the inspiration of him starting this interventional radiology. And he was of the thought process that if a plumber can do it to the pipes, why can't I do it to the vessels? Thank you for your time.